The EKG machine will capture the electrical current moving across the heart and give us something we can see and work with. In a normal working heart and rhythm, one beat signal should look like this. One beat includes a P wave, QRS complex, and a T wave. P wave represents the atrial depolarization, the electrical current flowing through the atria. And once P wave appears, the two atria will contract. Remember, electrical comes before the mechanical. We always expect to see this little hump before every QRS complex. That means if it's not obvious that it's there, then there's some sort of dysrhythmia in the atria. Could be atrial flutter if it looks like sawtooth, or AFib if it looks like a toddler trying to squiggle a line before the QRS complex happens. QRS complex represents the ventricular depolarization, that is, the electrical current flowing through the ventricles. When we see the QRS complex, the next thing we expect is that the ventricles should contract and you should feel the pulse when the ventricles contract. T wave represents ventricular repolarization. That means the resting phase for the ventricles. No electrical current should be flowing through the ventricles at this time. The muscles are trying to get back to their baseline and allow for the ventricles to fill in with blood from the atrium. If the T wave is very tall, almost as tall as the QRS, that's a peaked T wave. It's a sign of hyperkalemia, too much potassium in the patient's blood. If the T wave is inverted or upside down, possible ischemia in the heart muscles. And if the T wave is flat, we are worried about hypokalemia. The patient is low on the potassium. So P wave represents atrial contraction, QRS ventricles contracting, and T wave ventricles relaxing. I have a question. When does the atria relax? Where is the wave for the atrial repolarization? Stay with me and I will answer this at the end of this video. Okay, let's talk about the PR interval. PR interval is the distance from the start of the P wave to the start of the QRS complex. PR interval represents the number of seconds it takes for the electrical current to move from the SA node to the atria until it gets to the AV node or the AV node conduction system. A normal range is 0.12 to 0.2 seconds. If this time is prolonged, then we suspect some blockage within the AV node conduction system. And this is where we start talking about heart blocks. So we expect some sort of delay from that's between 0.12 to 0.20 before the AV node can release the electrical signal to the ventricles. And this is because it's giving the ventricles a bit more time to finish relaxing or repolarizing and filling. Then it releases a signal to the ventricle muscle so that it gets depolarized and contraction should happen. However, prolonged PR interval is no bueno. It's signs of heart block. ST segment is usually unusual, but when it happens, we see it with ST elevation or ST depression. ST depression is a sign of ischemia of the heart muscles or hypokalemia or digoxin toxicity. So, if a patient is on digoxin and their EKG shows depressed or almost flattened T wave, check their potassium. Hypokalemia increases the risk for digoxin toxicity. ST elevation is usually suspected with myocardial cell death or STEMI, ST elevation myocardial infarction. QT interval represents QRS, the time from the QRS complex to the T wave, the time it takes for the ventricles to contract and relax. Prolonged QT interval, we suspect hypomagnesemia or hypocalcemia, or the patient could be on some medications that can cause prolonged QT interval. For example, medications like amiodarone and some antibiotics. The issue with prolonged QT is that the patient can get into an arrhythmia called Torsades de Pointes. It's a type of polymorphic VTAC. Solution here is to give that patient magnesium ASAP and hold the medications if patient is on a medication that prolongs QT interval.